My name is Anna Rutherford. I'm the Clinical Director of Hepatology at Brigham and Women's Hospital and the Assistant Professor of Medicine at Harvard Medical School. I'm going to be speaking today about acute liver failure. I have no disclosures relevant to this presentation. What I'm going to cover today is the definition of acute liver failure. I'll talk about the epidemiology and pathogenesis of acute liver failure. I'll mention some specific therapies of acute liver failure, and management of complications, assessment of prognosis and outcome in acute liver failure. Acute liver failure is most reliably defined by evidence of a coagulopathy, an INR of at least 1.5, any altered mentation or encephalopathy, a length of illness less than 26 weeks in the setting of no pre-existing liver disease. It's a rare disease, about 2,000 cases per year in the United States. Therefore, no one medical center can study the condition. There are a variety of etiologies that also have a variety of treatments and outcomes. There's no viable treatment for all patients. Prior to liver transplantation, morbidity and mortality was approached 94%. Patients with acute liver failure can be listed as UNOS status 1 for 7 days. This means they surpass the MELD sodium score on the transplant list and likely get the next available organ in their blood type. Prior to the 1980s, hepatitis B was greater than 40% of cases of acute liver failure. If you look at the etiology of acute liver failure in adults within the United States, this is data acquired from the Acute Liver Failure Study Group, which has been studying acute liver failure since 1998 within the United States and collecting serologic data as well as liver tissue. About 46% of cases of acute liver failure are related to acetaminophen. Another 11% are related to other drugs. Hepatitis B is about 7%, hepatitis A about 3%, autoimmune hepatitis about 5%, ischemia or shock liver about 4%, Wilson disease about 2%, and there's a large group of indeterminate about 14%. When you contrast this to other countries around the world, it's really interesting. The United Kingdom also has a significant number of cases of acute liver failure due to acetaminophen, more so than in the United States. Whereas if you look at Southeast Asian countries like India or Bangladesh, the predominant cause of acute liver failure is viral hepatitis, hepatitis E and B in particular. So there are a number of different etiologies of acute liver failure, and with these there are distinguishing clinical characteristics. If you look here at some of the most common causes of acute liver failure, you can see there's a difference in terms of median age, as well as predominance of male or female gender. There's also some clinical differences in presentation. Someone with acetaminophen-related acute liver failure has a short jaundice to coma score, meaning they get sick very, very quickly and often present in grade 3 coma. Whereas someone with drug-induced acute liver failure may spend a longer time developing jaundice before presenting with altered mental status, which is part of the definition of acute liver failure. You can also see there are differences in terms of median ALT and bilirubin numbers. The most clinically important significance or difference between these different etiologies is the transplant-free survival. So you can see about 65% of patients who have acute liver failure due to acetaminophen will survive without need for a liver transplant, in contrast to about 29% of patients who have acute liver failure due to other drugs will survive without a liver transplant. Hepatitis A is also has a better outcome in terms of transplant-free survival when contrasted with hepatitis B or patients with indeterminate acute liver failure. Acetaminophen, it's the number one cause of acute liver failure in the United States and the United Kingdom. It's a $1 billion problem. It is an over-the-counter medication. There are greater than 300 brands. It has a unique dose-related toxicity and involves 100,000 calls to poison control annually, about 50,000 ER visits per year annually for acetaminophen overdose, 10,000 hospitalizations per year, and between 100 and 500 deaths per year. One of the issues with acetaminophen is it is linked to narcotics. Hydrocodone and acetaminophen is the #1 generic prescription drug. Over 100 million prescriptions per year is known as Lorcet, Lortab, Vicodin, Zydome. Because this was also a significant problem in the United Kingdom since 1998, Britain has limited package size of acetaminophen-related medications to 16 to 24 pills and employed blister packs. This prevents patients from taking very large bottles of acetaminophen, such as you would buy at Costco, and eating them all at once. And this has borne out to decrease complications of acetaminophen-related acute liver failure and hospital admissions, transplant, and deaths by 27 to 33%. The US FDA has been aware of this data and been implementing recommendations since 2009, where they are trying to separate doses of acetaminophen or keep the maximum dose of acetaminophen paired with a narcotic to 325 milligrams per day. So you can see Tylenol with codeine, hydrocodone, and acetaminophen can have as much as 750 milligrams of acetaminophen per tablet, which can very quickly lead to problems. So just to review the metabolism of acetaminophen, it is processed by the cytochrome P452E1 enzyme and becomes a highly reactive intermediate known as N-para-aminoquinamine. If glutathione stores are either limited, depleted, or overwhelmed, NAPQI binds to cell protein and forms cysteine adducts, which are highly toxic to liver cells. In patients who have enough glutathione who are given N-acetylcysteine, the antidote to acetaminophen toxicity, which is large quantities of glutathione, the N-para-aminoquinamine will be converted to a non-toxic mercaptic puric acid, which can be renally excreted. This is the basis for the antidote to acetaminophen toxicity, N-acetylcysteine, which is one of the treatments that we have for this particular toxic injury. So about half of the cases of acetaminophen-related acute liver failure are due to intentional acetaminophen overdoses versus unintentional acetaminophen overdoses. An intentional acetaminophen overdose is taking a large quantity of acetaminophen one time in an attempt to kill oneself. Unintentional acetaminophen overdose is usually taking a large quantity of acetaminophen over several days, usually linked with narcotics, unaware of the increasing toxicity with high doses of acetaminophen. If you look at the comparison of these type of cases in patients who presented with acute liver failure, they're mostly women. The dose in an intentional overdose is 25 grams of acetaminophen versus 20 grams over several days. Patients are more likely in the unintentional group to present with an advanced coma grade. Liver tests are very elevated in both situations. Patients who have intentional overdoses are more likely, not surprisingly, to have a history of depression and suicidality, although both groups have a 37-38% likelihood of using antidepressants. As you can see in the unintentional, the majority of these patients are taking multiple preparations of acetaminophen, and most are linked with narcotics. Interestingly, and probably good news is that in both groups, the transplant-free survival remains very high. 64 to 66% of patients will survive acute liver failure due to acetaminophen without need for a liver transplantation, and just a minority will get a liver transplantation. Other types of drug-induced liver injury that cause acute liver failure comprise about 11% of ALF cases overall. 70% of these patients are women. And in this group, as opposed to the acetaminophen-related acute liver failure, about 30% will survive without a liver transplant. So this has a much less favorable outcome. Most cases of acute liver failure due to acetaminophen occur within the first 6 months after drug initiation, and they're mostly described as idiosyncratic drug-related injury. About 46% of these drugs are antimicrobials. Complementary alternative medications are almost a quarter of the cases that cause acute liver failure, and things like antimetabolites, NSAIDs, and biologic agents cause another 27% of acute liver failure. The Drug-Induced Liver Injury Network has published cases of many of the medications that have caused acute liver failure. You can access these on the LiverTox website, where there's a specific category of drugs that have caused acute liver failure. Other case reports on this website will talk about different patterns of drug-induced liver injury. As you can see, there are a large number of antimicrobials, biologics, but a growing number of these are complementary alternative medicines, as you can see on the lower right. Viral hepatitis causing acute liver failure, the most common type of acute liver failure from viral hepatitis is from hepatitis B, about 7%, hepatitis A, about 3%. There are no reported cases of acute liver failure related to hepatitis C alone. There's also no increased risk of developing acute liver failure from hepatitis A in patients with chronic hepatitis C, despite recommendations for patients with hepatitis C to be vaccinated against hepatitis A and B. Hepatitis A most commonly occurs in the United States in epidemics related to food contamination. Hepatitis B most commonly occurs in the setting of chemotherapy reactivation. Other viruses that have been known to cause acute liver failure include parvovirus, B19, hepatitis D and E, SEN virus, dengue, HSV, and VZV. Wilson's disease, about 5% of patients who present with Wilson's disease will present with acute liver failure. This is nearly always fatal without liver transplantation, and some of the particular clinical characteristics of patients with acute liver failure from Wilson's disease include a very high bilirubin, a very low alkaline phosphatase, an alkaline phosphatase to bilirubin ratio of less than 2, hemolytic anemia, acute renal failure. These patients also will have Kaiser-Fleischer rings 50% of the time, and if biopsied, these patients are usually cirrhotic despite an acute presentation. So there are ways to rapidly diagnose whether Wilson disease is the cause of acute liver failure. This was a study published in 2008 where you look at the ceruloplasmin on whether it's less than 20, the alkaline phosphatase to bilirubin ratio of less than 4, AST to ALT greater than 2.2, and if you combine these three factors, this has a sensitivity and specificity of 100% in diagnosing Wilson's disease. This is important, as I mentioned earlier, because most patients who have acute liver failure from Wilson's disease will not survive without a liver transplantation, and this can certainly mobilize a transplant center to evaluate a patient for liver transplantation. Other etiologies of acute liver failure include toxins, Amanita phalloides mushrooms, some organic solvents, as mentioned before, herbal supplements, patients with acute fatty liver of pregnancy or Ray's syndrome, vascular injury including shock or Budd-Chiari veno-occlusive disease, heat stroke, or hepatic artery thrombosis, which is a complication of liver transplantation. Other things that can cause acute liver failure include autoimmune hepatitis, tumor infiltration of the liver, and primary graft nonfunction, which is again a complication post-liver transplantation, which presents much like acute liver failure. So very generally, the pathogenesis of acute liver failure involves massive hepatocyte necrosis and apoptosis. This obviously causes a release of cellular contents and contributes to many of the components of hepatic failure, which we'll review. Massive cytokine storm and hopefully some hepatocyte regeneration is also stimulated. So if you look at the entire patient presenting with acute liver failure, things in addition to the components of loss of the components of liver failure affecting the liver, the loss of metabolic function, including decreased gluconeogenesis, resulting in hypoglycemia at very late stages, inability to clear lactate, causing lactic acidosis, inability to clear ammonia, causing hyperammonemia, and decreased synthetic capacity, causing coagulopathy. Patients will often have acute lung injury or acute respiratory distress syndrome, some bone marrow suppression, impaired leukocyte function, causing patients' inability to mount responses to infection and also contributing to their risk of sepsis. In the brain, we can worry about hepatic encephalopathy, cerebral edema, and ultimately intracranial hypertension. Heart will often have a high output cardiac state and some subclinical myocardial injury if you measure things like troponins. Pancreas, sometimes pancreatitis, is part of the presentation, particularly in patients who have acetaminophen-related acute liver failure. Patients are often relatively adrenally insufficient. There is often kidney dysfunction or failure in late stages of acute liver failure. And patients with really profound hepatic necrosis can develop portal hypertension, which can mimic chronic liver disease or cirrhosis. So the specific acute liver failure therapies that are data proven are fairly minimal. N-acetylcysteine is definitely beneficial in patients with acetaminophen-related acute liver failure and has some benefit in early stage cases of patients with non-acetaminophen acute liver failure. In patients with pregnancy-related acute liver failure, prompt delivery of the baby, and liver transplantation. Other therapies that are used and have some data to support them, but not entirely data-driven, include giving high-dose penicillin or sibillinin, also known as milk thistle, for Amanita phalloides mushroom poisoning, corticosteroids and autoimmune hepatitis in patients with Wilson disease, copper chelation, plasmapheresis, and some antioxidant therapies. In patients with acute liver failure from hepatitis B, oral antiviral therapy is indicated. This is in contrast to patients who have acute hepatitis B without evidence of acute liver failure. They should not be receiving oral antiviral therapy. Acyclovir for patients with HSV-related acute liver failure, surgical decompression or TIPS in patients with acute Budd-Chiari, and in patients with ischemic liver injury or shock liver, obviously hemodynamic support. So N-acetylcysteine is been long used for acetaminophen-related acute liver failure. It works best within the first 48 hours after presentation, but it should certainly not be withheld even if acetaminophen ingestions are greater than 48 hours prior. Oral N-acetylcysteine is first-line therapy in patients with no or mild hepatic encephalopathy. It does not taste very good, but if patients have significant encephalopathy or develop nausea or hypertension, a transition to IV is definitely recommended. There are no firm guidelines about when to stop giving N-acetylcysteine, but most hepatologists will recommend giving N-acetylcysteine consistently until there's firm evidence of improved hepatic dysfunction, improved hepatic encephalopathy, improving INR, and declining transaminases. A study done in 2009, which is a placebo double-blind trial, looked at IV N-acetylcysteine in patients with non-acetaminophen-related acute liver failure. This was a total of about 270 patients who were randomized to either receive IV placebo or N-acetylcysteine upon presentation. Overall, there was no statistically significant difference in either survival or avoidance of liver transplantations, and the transplant rates were fairly similar. The only group that did perhaps show some statistically significant benefit were patients who received N-acetylcysteine in early coma grade when they presented to the hospital. These patients tended to survive without liver transplantation. Overall, the side effects were minimal except for nausea and vomiting, which occurred slightly more in the N-acetylcysteine group. So my conclusion from the study and the practice in many places is if someone comes in with acute liver failure, N-acetylcysteine should be given, particularly if they present with early coma grade, in hopes of enhancing their chances of transplant-free survival, and there are very few downsides to giving patients this medication. Liver transplantation, again, is one of the other data-proven cures of acute liver failure. Each year, between 3 to 6% of patients listed for liver transplant are listed because of acute liver failure. Overall, about 45% of acute liver failure patients that are listed for liver transplant will, about 25% of them will receive a liver transplant. As mentioned, patients are able to be listed status 1 for 7 days. This really implies that they are likely to die without a liver transplant within 7 days and allows them to surpass patients on the liver transplant list listed with a MELD sodium for chronic liver disease causes. Patients who receive a transplant for acute liver failure have a 90% survival at 1 month, about a 70% survival at 1 year. Most diseases, fortunately, do not recur. There have been reported cases of patients with repeated overdoses of acetaminophen, and there's also been cases of autoimmune hepatitis recurring post-liver transplantation. Non-specific therapies for acute liver failure include a couple of things we'll talk about here. Therapeutic hypothermia has been thought to be beneficial in patients with acute liver failure, and this was a retrospective cohort study in patients with advanced encephalopathy, grade 3 or grade 4 encephalopathy. They were cooled to 32 to 35 degrees. There were 97 ALF patients and 1,125 controls. The intracranial pressure was measured in about 39% of the patients who were receiving therapeutic hypothermia and 22% of the controls. Therapeutic hypothermia was not associated with increased bleeding or infections, as has been the case in some other clinical trials looking at therapeutic hypothermia. The only group where there was a slight trend towards improvement in survival was in patients who were less than 25 years old who had acetaminophen-related acute liver failure and received therapeutic hypothermia. But in the study overall, using therapeutic hypothermia did not affect 21-day overall survival or transplant-free survival. Other nonspecific therapies for acute liver failure include hepatic assist devices. These are fairly simply divided into cell-based and non-cell-based systems. Non-cell-based detoxification systems can involve single-pass albumin or plasma exchanged. Some of the devices you may have heard of are Prometheus or Mars. These are closed-loop devices. Cell-based systems are designed to provide both metabolic support and detoxification. There are 5 that have been assessed clinically, including ELAD, Hepatassist, and they differ among them in terms of cell source, mass, and whether they are using plasma or whole blood. All of these appear to be fairly safe with some biologic effect. They have been studied both in the United States and worldwide, though none has yet received FDA approval in the United States. So moving on to management of complications of acute liver failure, keep in mind the leading causes of death in patients with acute liver failure are cerebral edema and sepsis. We'll talk a little bit about management of hepatic encephalopathy, infection prophylaxis, use of sedation and analgesia, need for correction of coagulopathy, nutrition, circulatory dysfunction, cerebral edema, and finally assessment of prognosis and need for liver transplantation. So just reviewing how we grade hepatic encephalopathy, this can vary from grade 1 encephalopathy, which is mild confusion with maybe some incoordination or a slight tremor, to a coma, which can involve decerebrate posturing or loss to stimuli. In terms of managing hepatic encephalopathy in patients with acute liver failure, Many patients are given lactulose in hopes of lowering ammonia levels. It's important to try to avoid intravascular depletion or hypernatremia. There's not really good data to support use of non-absorbable antibiotics, including rifaximin, which we use in patients with acute hepatic encephalopathy. However, these are very commonly used. Neomycin, another medicine used for hepatic encephalopathy, is contraindicated in acute liver failure because of its risk of nephrotoxicity. In any patients with advanced encephalopathy, grade 3 or 4, it's certainly recommended to consider intubation to avoid mostly aspiration. So, moving on to infection prophylaxis, lung is the most common source of infections in patients with acute liver failure, followed by urinary tract and blood infections. Fungal infections can occur in up to a third of acute liver failure patients. There's not good data to support routine antibiotic prophylaxis in all patients with acute liver failure, particularly if they are in early stages of encephalopathy, stages 1 or 2. It is recommended that patients have daily surveillance blood cultures and chest x-rays, as acute liver failure patients may not exhibit standard infectious signs. There is data to support empiric antibiotics, including antifungals, if surveillance culture has a significant isolate, if there's a progression to or presentation with advanced hepatic encephalopathy, stage 3 or 4, or if patients develop refractory hypotension or presence of SIRS. In terms of managing sedation and analgesia, patients who are agitated or in pain certainly runs a risk of increasing intracranial pressure. Propofol and benzodiazepine seem to be the most common medications for sedation, though there is some risk of exacerbating hepatic encephalopathy. Propofol is important to consider because the recovery is short, allowing for quicker neurologic examination, which is important in patients with advanced hepatic encephalopathy. Propofol also may decrease cerebral blood flow and lower intracranial pressures. Analgesia, including morphine and Demerol, are not recommended due to their active metabolites accumulating in patients who cannot process those medications due to their liver failure. In terms of correction of coagulopathy, interestingly, despite very elevated INRs, spontaneous, clinically significant bleeding is pretty uncommon in patients with acute liver failure, about less than 10%. Everyone should be assured of being vitamin K replete by receiving 10 milligrams of vitamin K sub-Q for 3 days. There's no data to support prophylactic fresh frozen plasma to adjust the INR, and actually the INR is one of the best prognostic signs we have in any patients with liver disease, so that would reduce our ability to follow this. In patients who have hypofibrinogenemia, cryoprecipitate is recommended. And if there is a procedure that needs to be done, which involves a high risk of bleeding, particularly in these coagulopathic patients, recombinant factor 7A is recommended. This would include in patients who need a liver biopsy or who are having an intracranial pressure monitor placed. There is good data to support either an IV proton pump inhibitor or an IV H2 receptor antagonist to reduce risk of GI bleeding in acute liver patients. So nutrition, traditionally patients with hepatic encephalopathy, there was recommendations to protein restrict, but acute liver failure, as with most advanced liver disease, is really a catabolic state. So focusing on high protein diets is important. No data to say that a high protein diet is more likely to precipitate hepatic encephalopathy or the more feared cerebral edema. Enteral nutrition, whenever possible, is important in these patients. Thinking about higher caloric density feeds can avoid excessive free water, which can precipitate cerebral edema. And hyperglycemia can also exacerbate intracranial hypertension. So keeping a blood glucose of less than 150 is important. Obviously, blood glucose needs to be followed because in the very advanced stages of acute liver failure, patients can develop hypoglycemia, so keeping this within a narrow window of about 90 to 150 is important. In patients with circulatory dysfunction, including a systolic blood pressure of less than 90 or a mean arterial pressure of less than 65, it's recommended to use vasopressors. These can also be used to help achieve a cerebral perfusion pressure of 50 to 80 millimeters of mercury. Norepinephrine has been shown to generate consistent, predictable increases in cerebral perfusion in patients who have head trauma. Has not been studied specifically in acute liver failure. In patients who have refractory hypotension, consider relative adrenal insufficiency is a pretty common occurrence, and IV hydrocortisone is definitely indicated in this group. So in looking at whether hepatic encephalopathy predicts cerebral edema, a feared complication of acute liver failure, it's very interesting that most patients who develop cerebral edema, the majority, will present with very advanced encephalopathy, coma, or really marked somnolence, grade 3 or grade 4. It's very uncommon for patients with early stage encephalopathy to develop cerebral edema. Also, looking at admission ammonia levels and whether this predicts cerebral edema. And someone who presents with an ammonia level of less than 75 very rarely develops intracranial hypertension. An ammonia of greater than 100 is an independent risk factor for high-grade encephalopathy, and an ammonia of greater than 200 at admission can predict intracranial hypertension. These patients should have very careful neurologic monitoring. How do we prevent cerebral edema? First of all, consider in which presentations this is more likely. It tends to occur in the most acute liver failure presentations, something like an acetaminophen overdose. Patients with advanced encephalopathy should be intubated and also undergo a head CT. Again, we saw that most of the cerebral edema occurs in patients with stage 3 and stage 4 encephalopathy. There are no randomized studies to guide indications for intracranial pressure monitor placement. Most centers will place intracranial pressure monitors if patients have advanced encephalopathy, and they are also listed for liver transplantation. These are not without significant risk. Complications occur in this group of patients with monitor placement in 10 to 20% of patients. Other things to focus on include a quiet environment with limited stimulation, elevating the head of bed to about 30 degrees, mild hypothermia, so if someone's on CVVH, should not be treated. Corticosteroids are not really helpful in cytotoxic cerebral edema. Severe sustained intracranial hypertension, which is refractory to medical therapy, as a strong predictor of brainstem herniation and poor neurologic recovery post-liver transplant. These patients will often be delisted and not offered a new organ. There's really no data to support empiric use of treatments such as mannitol to reduce intracranial pressures. If a patient has been found to develop cerebral edema, it's important to involve neurosurgeons early. Other things that appear beneficial include giving hypertonic saline boluses to achieve a serum sodium of about 145 to 155. Some hyperventilation-induced hypocapnia, driving a PCO2 down to 30 millimeters of mercury. If a patient has intracranial pressure of greater than 25 millimeters of mercury for a sustained period of greater than 10 minutes, first-line therapy is mannitol. If patients are refractory to mannitol, this often can be used once and then is not as effective in follow-up. Barbiturate comas with pentobarbital or thiopental have been shown to be beneficial, and there's no randomized controlled trial data on therapeutic hyperthermia as a treatment for cerebral edema and acute liver failure. So how do we assess prognosis or need for liver transplantation in these very sick patients with acute liver failure? As we reviewed earlier, etiology is really an important outcome determinant. Depending on the etiology, patients have a wide variation in how likely they are to survive without need for a liver transplantation. Unfortunately, no prognostic criteria, though many have been looked at as both sensitive or specific, King's College criteria is probably the most specific of tests. Keep in mind that the King's College criteria exists both for acetaminophen-related acute liver failure and non-acetaminophen acute liver failure, and they're slightly different equations. A MELD of greater than 32 is fairly sensitive, 77% sensitive in terms of predicting who needs to be listed for a liver transplantation. So overall, King's College criteria is the most specific of these prediction models, and a MELD of greater than 32 is the most sensitive. Other things that have been looked at are factor 8 and 5, arterial phosphate and lactate, ammonia levels, serum apoptosis markers, Apache scores, and alpha-fetoprotein. About 90% of patients will have a definitive outcome at 3 weeks. About 45% of patients overall with acute liver failure will survive without need for liver transplant. About 25% of patients will undergo a liver transplant, and about 30% of patients will die without a liver transplant. Keeping in mind of predictors of outcome, etiology is very important. Patients who have acetaminophen-related acute liver failure, 65% of these patients will survive without a transplant. However, if they are thought to have acute liver failure related to some other drug, their overall transplant-free survival is much less at 29%. Also, patients with indeterminate etiology of acute liver failure have a fairly dismal transplant-free survival, whereas hepatitis A has a very good likelihood of transplant-free survival, even compared to hepatitis B. So figuring out as best one can what the cause of the acute liver failure has a lot of implications. So why do only 25% of patients with acute liver failure receive a liver graft? This is probably because this is a very rapidly fatal disease. There's organ shortage throughout the United States. There's also no hepatic assist devices that are FDA approved, so we're not really able to bridge patients to liver transplantation. Prognosis, as well as determining who might need a liver transplant, is pretty difficult to assess. Late presentation can preclude transplant listing. And some patients are not transplant candidates due to other diseases or psychosocial reasons. If you look at patients who have been transplanted for acute liver failure, interestingly, in the first year after transplant, their survival is somewhat less than patients who are transplanted for all other etiologies of chronic liver disease. Somewhere around year 3 post-transplant and beyond, up to 10 years post-transplant, these patients' overall survival is better than patients with chronic liver disease. I think this initial dip in the survival curve is probably because these patients are so sick going into transplant, so acutely ill, and probably this long-term overall survival benefit may be related to patients who have recurrent hepatitis C post-transplant who are transplanted for chronic liver disease, and this may change with newer hepatitis C treatments that we have available now. Interestingly, also, there's a difference in survival for different etiologies of acute liver failure. So patients who are transplanted because of acute liver failure due to hepatitis A or B or acetaminophen have a better post-transplant survival than patients who are transplanted for drug-induced acute liver failure or indeterminate. So in summary, acute liver failure is defined as a coagulopathy, INR of at least 1.5, with encephalopathy onset in someone in less than 26 weeks. Acetaminophen plus other drugs are over 50% of the etiology of acute liver failure in the United States. Good prognosis or good of patients who present with acute liver failure include acetaminophen, hepatitis A, and shock. Patients with a poor prognosis who are likely to not survive without a liver transplantation include patients with drug-related acute liver failure, indeterminate acute liver failure, hepatitis B-related acute liver failure, and Wilson disease. Liver transplantation has improved overall ALF survival. If you add up all the different etiologies of acute liver failure, 45% of patients will survive without a liver transplant. There is some benefit to IV N-acetylcysteine in all etiologies of acute liver failure, particularly in non-acetaminophen-related acute liver failure in patients with early encephalopathy. Patients who present with a worse admission coma grade 3 or 4, have a worse prognosis. And there are limited effective clinical prognostic markers in acute liver failure. Think about the King's College criteria and the MELD score, but etiology is often the most helpful. These are some recent references. And I move on to the board questions. So question 1, a 19-year-old male presents to his primary care doctor with 2 weeks of postprandial nausea and abdominal pain. His labs are noted below. Based on his presentation, your working diagnoses would include. So he has labs done on June 3rd and then again on June 6th, which are notable for very high AST and ALT, and a quite high total bilirubin and direct bilirubin, as well as an INR of 2.3. So based on this presentation, your working diagnoses would include A, acetaminophen, viral hepatitis or Wilson disease. B, drug-related acute liver failure, viral hepatitis or alcoholic hepatitis. C, Amanita phalloides, Wilson disease or viral hepatitis. D, shock liver, autoimmune hepatitis or acetaminophen. Or E, viral hepatitis, Wilson's disease or autoimmune hepatitis. So the correct answer is E. This could be a presentation of acute liver failure due to viral hepatitis, Wilson's disease, or autoimmune hepatitis. In the question, response A is incorrect because this patient presented 3 days apart after 2 weeks of some symptoms that are likely attributed to his liver failure. So acetaminophen is a much faster protagonist of acute liver failure. In answer B, alcoholic hepatitis would not cause transaminases nearly this high, though it can certainly cause jaundice and coagulopathy. In C, there Amanita phalloides mushroom toxicity, there's no history of ingestion. In D, shock liver, autoimmune hepatitis, and acetaminophen, again, acetaminophen would not present over 2 weeks of sort of progressive malaise and jaundice. The patient is sent to the emergency room and is found to have a total bilirubin of 20. His INR is 3.2. Tylenol level is negative. He's negative for acute hepatitis A, B, and C. He has an ultrasound that shows biliary wall thickening and normal Doppler flow in the portal and hepatic veins. He has not had any, not on any medications. He hasn't been taking any over-the-counter supplements, herbal medications, or mushrooms. He has no history of IV drug use. He's had no recent sexual exposures or travel exposures, and he's a very rare alcohol user. Over the course of his emergency room evaluation, he becomes sleepy and slightly confused. Your next steps in his management should include A, admit to ICU, intubate, give FFP to keep INR less than 1.5. B, serum and urine tox screen, IV NAC, and hypertonic saline. C, IV NAC, head CT, refer to transplant center. D, slit lamp exam, IV steroids, and lactulose. Or E, plasmapheresis, D5W, refer to transplant center. Here, the correct answer is IV N-acetylcysteine, head CT, and refer to a transplant center. Answer A is incorrect, though if you're worried about hepatic encephalopathy, obviously admitting, and acute liver failure, admitting someone to an intensive care unit is important, and potentially intubating them as well. There's no data to support using FFP to keep an INR less than 1.5, and actually an INR is a good prognostic indicator. And if someone is having significant bleeding or an invasive procedure, should let their INR leave it alone. In B, serum and urine tox screen is a good idea. IV N-acetylcysteine is also a good idea in early stages of hepatic encephalopathy. Hypertonic saline is a treatment really if someone has documented cerebral edema, and there's no data to support using empiric treatment for cerebral edema. D, a slit lamp exam is not a bad idea in a young patient who presents with acute liver failure. In someone who is confused, giving him PO and acetylcysteine, not a bad idea. And lactulose could be used if someone is encephalopathic. E, plasmapheresis is a treatment used in patients with known who are diagnosed with acute liver failure related to Wilson's disease. D5W is only beneficial in patients who have hypoglycemia, and referring to a liver transplant center is obviously a good idea. So in question 3, if this case were determined to be an unintentional acetaminophen overdose, which of the following statements is true? And the caveat here is that this doesn't really present like an acetaminophen overdose, but if it did in terms of the lab testing and the other clinical presentation. A, due to chronic acetaminophen toxicity, the patient is unlikely to survive without a liver transplant. B, patient would not meet criteria for transplant listing as he is likely addicted to narcotics. C, men are far more likely to take unintentional acetaminophen overdoses than women. D, a patient's chance of transplant-free survival is about 65%. Or E, N-acetylcysteine is not effective in unintentional acetaminophen overdoses due to the long time between ingestion and presentation. Here, the correct answer is D, the patient's chance of transplant-free survival is about 65%. Patients who have both intentional and unintentional acetaminophen overdoses as the etiology of their acute liver failure have a very good transplant-free survival of about 65%. Other answers are incorrect. A, because there is no such thing as chronic acetaminophen toxicity. B, though patients with unintentional Tylenol overdoses are much more likely to be on narcotics, this does not necessarily mean that they are addicted to narcotics, and they should certainly be evaluated for liver transplantation if they do not appear to be recovering on their own. C is incorrect. Women are much more likely to have either unintentional or intentional acetaminophen overdoses. About 70% of patients with acute liver failure from acetaminophen are women. And E, N-acetylcysteine is not effective in unintentional acetaminophen overdoses due to the longer time between ingestion and presentation. This may be true. N-acetylcysteine is more effective within the first 48 hours. However, it should never be withheld. And its job is really to replete glutathione stores in hopes of converting the toxic metabolite of acetaminophen to a non-toxic mercaptopuric acid.